But this, what you see here is the logo of World Kidney Day. World Kidney Day is celebrated. Let's just say celebrated or marked on the second Thursday of March of every year, and it's jointly owned by the International Society of Nephrology and the International Federation for Kidney Foundations. So, the goal for the World Kidney Day is to spread the message of kidney health. And this year we have started framing it in the context of the universal health coverage, which is now part of the Sustainable Development Goals. So just to orient you, maybe you already know this, but some of those whose words don't intersect with the world of kidney, I think you might have heard of the term chronic kidney disease. So chronic kidney disease is actually not just one condition, but it's a continuum. And as you can see from left to right, is that we all start out as normal, healthy individuals in terms of kidney health, but a number of us develop conditions which increase the risk of future development of kidney diseases. For example, diabetes, hypertension, some other conditions, etc. And most of these conditions are the conditions that the researchers work on. So if those risk factors are not well managed, and in some people even after they are well managed, kidney disease still develops, and then it progresses through a level of severity, and eventually the kind of kidney disease that most of the time a common person understands is the one that is where people land up on dialysis or receive a kidney transplantation. So it's a spectrum, but we need to manage the whole spectrum of the condition. So let's start, and okay, we'll come to that slide later on. So why is kidney disease important? So kidney disease has moved up as in the list of the years of lives lost from number 24 in 1990 to number 16 in 2000, according to the Global Burden of Disease study. And what is even more scary is that by the year 2040 rolls along, this would have become number 5, in fact, as in the list of causes of death. So it is truly a public health problem. It has been identified as such, and there is a lot that we still need to learn about how to manage this burden of disease, and how to manage this in a way that is affordable, scalable, and sustainable for large parts of the world. So this graphic really shows you the entire continuum of chronic kidney disease. So starting from risk factors, there is an estimate that about 276 million people in the world have at least early stage, they have early stage chronic kidney disease. And we did some study, and I'll show you some of those details later on, which was published in the Lancet 3 years ago, where we estimated the number of people with end stage, which means the terminal stage of kidney failure, where people will need dialysis at about between 5 and 10 million people around the world in 2010. And we also estimated that out of these 5 million people, which is the lowest number in our estimate, just about half are able to get some treatment for it, and the other treatment because they can't afford it, or it's not available in their countries, and so on and so forth. And what is that treatment? That the most frequently recognized form of treatment is dialysis, and there are 2 types of dialysis. The one that almost everyone knows about is hemodialysis, but then there is another type of dialysis called peritoneal dialysis. And then the most definitive and the best form of treatment is kidney transplantation, but unfortunately only a minority of individuals with end-stage kidney failure are either or are able to get kidney transplantation. So most people have to content with being on dialysis. So let's just talk a little bit about dialysis. So how did dialysis start? So dialysis started because the technology became available in the late 60s and early 70s. And at that time in the United States, people thought that if this dialysis technology was to become available to maybe a small number of people. At that time, the thinking was that only a small number of people develop end-stage kidney failure, and these people are generally young. They're in the most productive years of their life, and if dialysis, this life-extending or life-sustaining therapy could be made available, they would be able to live long lives and they thereby contribute to the society. So there was a lot of drama, in fact, in US Senate. Nephrologists at that time, they were really very, very good in their advocacy, and they even took a dialysis machine and dialyzed the patient in the US Senate. And this really moved everyone, and all the senators, they supported this bill. And in 1972, Richard Nixon signed this bill, which is called the Public Law 92603 or whatever, which basically laid the foundation of US Medicare. And that is not something which is well known. And what it did is that it created this indication by discrimination, in the sense that dialysis was eligible for public funding for everywhere. So everyone. So that was that was the sentiment at that particular point of time, and people thought that there will be at most there will be a few thousands of people who will require dialysis, and then government should be able to support that. And at that time, what happened is then when people got to know around the world of availability of free dialysis in US, the first dialysis center was set up in Seattle. People from other parts of the world also started going to US to start receiving dialysis. And the person you see on this slide is actually a British medical student at that time. He traveled to Seattle. He worked as a medical technician just so that he could survive being on dialysis. And then he put himself through medical school, and he became a renowned dermatologist. And that's the person on the right. He just died a couple of years ago. So he lived on dialysis for 50 years. His name is Sir Robin Eadie, and he was a professor of dermatology in UK. So people went to great lengths to get themselves on dialysis. And even in the global medical community, the ability to provide dialysis became a kind of benchmark of the health system's willingness to take care of the people that it serves. And so the Australian guidelines say that availability of resources should not be a reason to deny a patient access on dialysis. So this has become a kind of ethical benchmark for providing dialysis. But we know that this benchmark is not available for most people around the world. So we asked the question a few years ago, and the answer to this was not known. How many people develop end-stage kidney failure? We were interested in India, but also we were interested in finding out what happens worldwide. One of the sources for this is this kind of figure, which is published by the United States Renal Data System every year, which shows you the number of people who develop end-stage kidney failure and receive treatment for end-stage kidney failure, which means dialysis around the world. And you can see easily, I think individual numbers and individual names are not important, is that there is at least 100-fold discrepancy between countries like Taiwan on top, which has an incidence rate of 476 per million population per year of treated end-stage kidney failure, and going down to Ukraine and Bangladesh, where this number is 26 or something like that. So there is a huge difference, and if you look at prevalence, difference is even bigger. It's very difficult for us to be able to explain this discrepancy by difference in human biology, because obviously human biology is not so different. That will be able to explain this difference. So obviously these differences are because of non-biological reasons. So just given that background, so in India, so what it tells you is that the only way for the world generally to express how many people develop end-stage kidney failure is for all these countries to just count the number of people who are receiving dialysis and then convert that into an incidence figure. But as I said, that number is not really reflective of the number of people who develop the disease, right? So in India, it was very difficult because the dialysis was not available until not universally available until a few years ago. So, and this story really tells, this is a bit of a serendipity, how we got. Most of you are not alive in 1984, but in 1984 in India, in a city called Bhopal, we had a big industrial disaster. So Union Carbide was a company, and it had an industrial accident leading to a leak of sarin gas in the city, and a lot of people died at that time. And so as a result of that disaster, more than 500,000 people were affected. And Union Carbide was fined, and Supreme Court of India set up a hospital to provide free healthcare to all the people who received the unique ID number. So this was the first instance where in India people were identified as individuals, etc., for receiving some sort of care, free care. And so in the year 2000, I was chatting with the nephrologist who worked in this hospital. And that is the time I realized that here is an opportunity for us to act, because all these people, more than 570, receive free healthcare. So if they develop a disease which requires expensive treatment like end-stage kidney failure, they will obviously come to this hospital. They won't go anywhere else. So this is an opportunity for us to find out the number of people who develop end-stage kidney failure in this population. And again, cutting a long story short, we did this, and we found that the number of people who developed end-stage kidney failure in this population is 226 per million population per year. So the first question you will ask is that maybe this number is not representative because this is people who are affected by this gas. But there is no bioplausibility of the effect of this gas on kidney. So it is unlikely the gas is affecting the incidence of kidney failure, and we think that this is the true number, at least in that city. But so far, we did this now almost 20 years ago, and so far this is the only reasonably accurate estimate of end-stage kidney failure, at least in India. So then the next question: how many people need dialysis worldwide? And we asked this question about 5 years ago, and so at the George we went out and looked at published literature, but we also contacted national societies and policymakers of a large number of countries, and we were able to get prevalence data from 123 countries. And you can see in the box the prevalence rates, and the color coding of the world shows you what are the different prevalence rates. But then there are a number of countries for which we didn't have any data, and so there in this figure they're shown in gray color. So the common narrative goes in the medical community is that development of kidney disease is linked to the burden of hypertension and the burden of diabetes, which is true in biological sense. But then if you look at the relationship of these two diseases with the number of people who actually get dialysis, which is different from, as I said before, different from the number of people who develop end-stage kidney failure, we found that there was no relationship between that number and the prevalence of diabetes and hypertension. So what we found was actually related to the number of people who received end-stage kidney failure was a measure of the situation of that given country so far as one, economic development is concerned, which is GNI per capita, and the second, the place in how good is healthcare in that country, which is reflected by life expectancy of the product. So then these were the only two parameters which sort of predicted the number of people who would be on dialysis. And we were by this publication, which also came around the same time from Latin America, and they also found more or less similar findings that the number of people on dialysis is directly related to the GDP per capita of the country and the life expectancy of the country. So then using those two numbers, Toshi Ninomiya, who's a statistician based at George Institute in Sydney, he did some sort of out with numbers which were used to then fill in those countries which were missing on the first map that you saw. And so then again, cutting a long story short, we found that the number of patients on dialysis in 2010 around the world could be estimated at about 2.6 million. And then we went around and we sort of tried to divide where these patients were located. And as you can see that most of these 2.6 million people, 1.4 million people were actually located in high income countries, 318,000 people were located in upper middle income countries and so on. And you can see that only a small proportion, which is just about 3.1%, are in low and low middle income countries, even though the population of these countries is disproportionately larger. And so this is basically shown in a different format: 62% in high income countries, 30.7 in upper middle income countries, and so on. So then when we analyze this further, a somewhat interesting finding emerged is that there are 4 countries in the world: Japan, Taiwan, Korea, and United States, where anyone dialysis and has a breath will receive dialysis. But there are many other countries, like, which includes UK and Australia and many European countries. They have a somewhat less permissive approach to putting patients on dialysis. And so they will look at other things, for example, comorbidities, if a patient has terminal cancer or dementia, etc. So they will not be considered eligible for receiving dialysis, perhaps. And so, so when you took the prevalence data from these countries, and if you try to use that data to project the number of people who should be receiving dialysis using the criteria which is used by US, Taiwan, Korea, and Japan, you will get a much larger number for the number of people who should be receiving dialysis around the world. And that goes up to almost double the number that you would get by conservative estimates. So that's an interesting finding. But even using estimate and the conservative estimates, even while using the conservative estimate, we found that the number of people who should be receiving dialysis in the world is or should be receiving renal replacement therapy in the world is about 4.9 billion, but only 4.9 million, but 2.6 million were receiving dialysis. So there is about 47% of people who should have been receiving dialysis are actually not. And this gap was really largest in Africa, 84%, Asia, 66%, and so on. And since we are using the conservative estimate, as you said, which was the estimate used, which was estimate based on data from Europe, Australia, etc. If you look at the North America cluster, it's very interesting that more people are receiving dialysis than should be eligible to receive dialysis. So that's that.
Why is that the case?
Why is that the case?
Why are we getting unnecessarily?
So it's not unnecessary. I shouldn't use the word unnecessary, but the criteria which is used in North America, as I said, are much more liberal. So let's just take an index patient, 85-year-old person who has advanced cancer, but develops end-stage kidney failure. He will receive dialysis in the US, but will not receive dialysis in UK, perhaps, because this dialysis is unlikely to significantly extend this patient's life or improve the quality of life also, right? But so it's an issue of the value system that the society places on providing particular treatment. So using this, this paper actually gave us these figures, and these figures are now used by the global nephrology community, including the International Society of Nephrology, in work. So this work came out of the George Institute. So the next thing is, as we have, the undercurrent is clear that treating people with dialysis is expensive. So what are the economic consequences of treating these people? And so again, a few years ago, we published this, and we showed that there is a linear relationship between per person GNI of a country and the prevalence of people who receive dialysis, at least in the lower part of the. But once a country attains a certain level of prosperity, then it kind of flattens off, right? So then it doesn't increase. And this, interestingly, you can show the same relationship even within a large country. So this is data from within India, and each individual dots represent a particular state in India. And so if you look at the income of a particular state in India and the number of people who receive dialysis, again, you can see linear relationship. So this is perhaps a very generalizable finding. Then we looked at even at micro level. So that was at macro level. We looked at what happens at micro level. So we looked at patient level information on what does it mean for people in a low middle income country where dialysis is not publicly funded or kidney transplantation is not publicly funded. And we found that state subsidy, so this work was done in the institution where I worked before coming to George. So it's a public sector hospital, and it's a large public sector, one of the largest public sector hospitals in India, located in North India. So, so people have to, compare to other hospitals which are managed by private organizations in India, people have to incur relatively lower amounts of out-of-pocket expenditure in these public sector hospitals. But what we found, so there is some amount of state subsidy because the doctors are paid for by the state, the infrastructure is paid for by the state, so patients don't have to incur any out-of-pocket expenditure, say for example, to cover doctor's fee and so on and so forth. But even there, what we found is that a large proportion of people experience catastrophic healthcare expenditure, and catastrophic healthcare expenditure, as perhaps most of you will know, is when than 40% of its non-food expenditure on anything like healthcare here. So almost 80% of people experienced, or 80% of families experience catastrophic healthcare expenditure. So much so that we came up with some new terminology. We use terminology like severe catastrophic healthcare expenditure, if that makes sense to anyone. When people spend actually more than 100% of their income. So how do they do that? They do that by, by what we call distress financing, by, for example, selling their property or taking loans and so on and so forth. So treatment of advanced kidney failure is not just a medical catastrophe or calamity, it is a social calamity and social catastrophe. So entire families get affected. And Beverly Issue at the Sydney office, she produced this report and she estimated that about 188 million people around the world, not around the world, in low middle income countries, experience catastrophic healthcare expenditure every year as a result of just kidney diseases, and that this number is actually the greatest of any other disease group, in fact, heart disease, lung disease, cancers, etc. Then comes the cost of, so when there is state subsidy of any treatment, we often stop thinking of how much it costs the state in providing a particular treatment. So we looked at that question, and we again went back to the same hospital where I worked in, and we looked at the cost of hemodialysis in a public sector hospital. And so this is something which many practicing physicians don't often think about as to what exactly are the cost components of providing a service. So we looked at the cost of everything, starting from the building, the equipment, the recurrent expenses on drugs and consumables, human resource, other consumables like even printing forms and collecting case records, etc. Overheads like electricity, water, and so on and so forth. And what we found is that the average cost which was incurred was, you can see the number there in Indian rupees and US dollars. And the number that we actually found as the true cost was almost 4, which people thought instinct. Then we went back and asked people, how much do you think it costs to dialyze a patient? And the number they came up was 1/4 of the actual number. So people don't have really a good perception of what it actually costs to provide a particular type of treatment. And then this is from the same paper. We looked at the distribution of both health systems cost and out-of-pocket expenditures. Side is the health systems cost, and you can see that a large proportion of the health systems cost is for example, 45% is on human resource, which is, since the state pays for it, it is often not counted as the cost of treatment, which obviously from an economist's point of view is incorrect. And the second or third largest section was the cost incurred, cost of the building and the cost of medical equipment. So which again, it just is free from somewhere, where of course it is not true. And in terms of the out-of-pocket expenditure, the biggest, almost 2/3 of the out-of-pocket expenditure was the cost of medicines that the patients had to buy. So often in India, for example, the government thinks that just providing dialysis treatment at the point of care, if they have done that, they have done the job. But then there are other components like medicines, etc., which the patient is still, and that can lead, that can actually add up to a large amount of money. Which so again, subsequently, we did these numbers, and the cost of dialyzing a patient for 1 year in different parts of the world varies between 35,000 to 100,000 in countries like US. And so clearly this number is unaffordable for many governments and individuals in large parts of the world. And these numbers are also now used by the global nephrology community for advocacy purposes. So then the next question, of course, is that large sections of society are now campaigning for making dialysis free. So what happens when dialysis does become freely available? And this is some work which we actually started initially talking about from here at Oxford. So there was in the year 2008, the state of Andhra Pradesh, which is in the southeast of India, it started some sort of public funding of dialysis at that particular point of time. So in the year 2013, we were able to access data from this insurance scheme. So this was a claims database, basically. And using this claims database, Marsh Sheikh, who was at that time a research fellow with the George Institute, he looked at what happens to people who receive dialysis. So obviously, as you can see that if some sort of service is made freely available, year on year, the uptake of people who start coming on treatment gets better, which is not a surprise. So looking at so these two, so let me just orient you to these two bars here. So the bar in the blue color is annual incidence. So new individuals who receive dialysis in that. So that you can see increased from 29 to 69 over a 4-year period of time. And the bar and the orange bar is the number of people dialyzed in that year. So if you can see, say for example, if about 29.5 per million population started dialysis in 2008, 2009, and 2009, 2010 you had 40. So you would expect to see at least the number of prevalent patients, the sum of these two, right? But you can see that the number of quote unquote prevalent patients is less than that, which means that a large number of people who started dialysis in the first year died in the second year, either died or just stopped taking dialysis. So that's something which is for you to just keep in mind. And this table simply is being shown to make the point that there is a big skew in favor of males receiving dialysis. And this is also not a surprise for India, although you think it will happen. But this is, again, data from the US RDS. And it shows you incidence rates of treated end-stage kidney failure patients. Blue bars are number of males, and the yellow bars are number of females. So you can see the yellow bars are smaller in almost all the countries. So perhaps there is gender discrimination across the world here, at least in access to dialysis, because it is very difficult to explain it just by biology. So then coming back to the Andhra Pradesh data, so just extending that point of why people are not, the prevalence is not increasing as much as you would expect. We found that almost 2/3 of the patients, despite the fact that dialysis treatment itself was available free, they were stopping dialysis for some period of time. And since we just looked at the claims data, we can't say what was the reason for it, but we suspect that it was because of the out-of-pocket expenditure which was involved in, say, for example, transport, getting to the dialysis center just 2 or 3 times every week, or medications, and some lost earnings because they can't go and work, etc. And that is something which we are now looking at now. And when we look at that in India, I mean, tragic that as it is, situation is even worse in many other parts of the world. And this is data from sub-Saharan Africa. And just I'll draw your attention to this box, is that you can see that just about 1.5% of dialysis in sub-Saharan Africa are still on dialysis at the end of the year. So 99 people out of 100 would have stopped in sub-Saharan Africa. So the situation is even more dire in many other parts of the world. So then you can actually, we came up this with figure is that if you look at in low middle income countries, what is the situation? So the outermost circle shows you the true burden of all individuals who develop end-stage kidney failure. Only a subset of that is even recognized in the system. Many don't even present to the healthcare system at all. Out of those who are recognized, a smaller number are able to access renal replacement therapy, and out of those a really small number are able to stay on renal replacement therapy like dialysis for a significant period of time. And this is the challenge which really stares the nephrology community in the face. And then there are a number of factors that potentially impact how a patient starts on dialysis and stays on dialysis. And we are now in a series of studies now. We are exploring many of these issues now. So looking at one of the things that we are doing right now is a study which has in which we have now a cohort of individuals who are starting dialysis, and we are following them over a period of time to find out their outcomes and what are the factors really of all those factors that we hypothesize potentially impact how they fare on dialysis. What are these factors, and maybe there are some other factors also. So currently we are doing this in 24 centers in India, and we are expanding this study to Bangladesh, Nepal, and Zimbabwe this year. And this is the study the protocol which was published. So as a result of our work, the state government of Andhra Pradesh, because we published it, asked us to actually audit their dialysis facilities. And this was the report that we published, and we told them that out-of-pocket expenditure on medicines was an important reason why people were not able to start dialysis. So as a result of our work, the government actually approved a payment of 2,500 rupees for every patient who is on dialysis to meet with this out-of-pocket expenditure. And just last week, this number has been increased to 10,000 rupees. So that was a direct impact of the work that we did for the governments, which was interesting. Now, looking at this as a global problem, the George Institute a few years ago with the International Society of Nephrology, with the Asia Pacific Society of Nephrology, came up with the idea of this affordable dialysis prize. So we announced a $100,000 prize, and these were the conditions that we identified as conditions for people who wanted to participate in this. So we received 7 entries, and we chose a winner at that point. And this is the winner, Vincent Garvey. He's an engineer, and this is the solution that he proposed. Would prepare peritoneal dialysis fluid at point of care using solar power, water from any source. It will be controlled by a smartphone, and it will cost around $500 for the entire kit, and the running cost will be like $5 a day. That's the premise on which he won it. So after that, Vince Garvey, who led a retired life in the Isle of Man, he has now relocated to Sydney, and with the George Institute set up a company now called LN Medical Devices. And so this was founded in 2016. And so it received last year more than $5 million funding from New South Wales Health, and also it received some funding from George Health Enterprises. And now the prototype has been developed, and you can see the picture on the right. And this is the product development timeline. So this is a work that directly came out of the series of publications that we did at the George Institute, leading to identification of a challenge and development of a potential solution. So then again, coming back from dialysis, or the most advanced stage of kidney failure, to earlier stages of kidney failure. So I shouldn't say kidney failure, but kidney disease. And so again, this is data from the Global Burden of Disease study, which looked at kidney disease prevalence around the world. And if you look at the legend on the map, just to orient you, orange or yellow is bad, and gray or blue is less bad. There is nothing which is good, but not less bad is all that I can say. And you can see immediately that the largest burden of kidney disease is in the poorest parts of the world, which is Africa, which is parts of the Middle East, South Asia, South. So we need to do something for it. So going from concentrating in our region, so we decided to actually measure or count the number of people with early stage chronic kidney disease in Asia Pacific region. And so for that, we put together at the George Institute a consortium called the Asian Renal Collaboration. And through that collaboration, we are currently, right now that manuscript has almost been finalized, and we now have a number of individuals that have chronic kidney disease in different countries in Asia. We used a somewhat similar methodology that was used to estimate the number of people with end-stage kidney failure around the world. And this paper will hopefully come out very soon. So now let me just change gears a little bit. When we try to identify people who have chronic kidney disease, the way we do it is what we call by measuring or estimating the glomerular filtration rate. So glomerular filtration rate is the ability of the kidney to filter blood. So because that is what we all understand instinctively as an important function of the kidneys. And the measuring glomerular filtration rate is very hard. So we measure a compound in the blood called creatinine, and using the value of serum creatinine, we use a formula to calculate or estimate the glomerular filtration rate. Now this is interesting that serum creatinine, although it's a universally accepted marker of glomerular filtration rate, the factors that determine the serum creatinine level in the blood are not necessarily linked just to kidney function. They are also linked to other parameters, for how much meat one eats, what is the muscle mass of the individual, etc. And so we realized, so there is a formula which was developed a few years ago in North America, in Caucasian population, and then there was a quote-unquote correction factor which was used to apply the same formula to African Americans, or to the black population, because their muscle mass is different, etc. And then the global nephrology community said that this is the formula that should be used by all countries around the world, or everyone, all ethnicities around the world to estimate glomerular filtration rate. So we actually tested the performance of this formula in Indian population, because as you would know, a majority of Indian population is vegetarian. Their body habitus is different. The muscle mass is generally lower than that of, say, for example, Caucasians or African Americans or blacks, etc. And so we measured the glomerular filtration. So actually measured the glomerular filtration rate using what is inulin clearance, which is a historically validated measure of glomerular filtration rate, and then we estimated the glomerular filtration rate using the formula which is recommended, and we found that the estimation equation actually overestimated the glomerular filtration rate in Indian subjects. So if we want to know what is the true burden of kidney disease in, for example, India, we can't do that with this formula. But unfortunately, that is the only tool that we have available to us. So right now we are in the process of doing a large-scale study in which we will actually measure the glomerular filtration rate, and we will also measure serum creatinine and develop a new formula which can be calibrated to the Indian population so that it gives us a more accurate result. And we did this, one of the things that we were able to show using data from Japan, because we were collaborating with the Japanese, is that it is likely linked to the muscle mass, because the creatinine is the molecule which is produced in muscles, right? And if you have lower muscle mass, the amount of creatinine which the body will produce will be lower. And so by measuring the urinary creatinine excretion, we were able to show that Indians consistently had a lower urinary creatinine excretion. We didn't compare with any other population. So there is at least some validation there. So now the final bit that I would talk about is this, and maybe some of you have heard of this story, is that hotspots of kidney disease have been described from a few parts of the world. That people in those countries or those geographic regions perhaps develop kidney disease at a much greater rate. And it has been called, so some of those, so you can see in North America, Central America, in South Asia, in India, Sri Lanka, in Southeast Asia, in some parts of Middle East, etc., and Northern Australia as well. So in India, in the state that I talked to you about earlier, Andhra Pradesh, so there is a coastal district called Uddanam. For the last 20 years, there have been reports in the lay press of high prevalence of kidney disease in that area. And no one knows even today what is the reason for it and why. And it was just a narrative which went on in the communities for a number of years, and it just became common knowledge. It even became a political issue that political parties, when they fought elections, they campaigned on that particular issue, saying that we'll solve it when we come to power. But nothing has happened in the last 20 years. So 2 years ago, we started, the Andhra Pradesh government funded us to actually investigate this. So this is the region. You can see this is the Bay of Bengal, and this is the coastal district of Srikakulam. So we just completed a systematic random sampling, and these are various administrative units in that region. They're called mandals, and in each mandal we selected a certain number of villages. And again, cut a long story short, we have now completed at least the epidemiological aspect, and we find that about 18% of people in that region have, in our survey, had chronic kidney disease, which is almost double the number that you would expect. The expected population prevalence should be between 9 and 10%. So it is double the number. Find that there is evidence of some clustering. So you can see that in the villages that we selected, the red squares are the villages where the prevalence rate is greater than 20%. The gray ones are 15 to 20%, and so on and so forth. So you can see that there is some clustering in this area. So perhaps there is something which we need to investigate as to what exactly is going on. And so we found a few things, and so we found a relationship between kidney disease prevalence and tobacco use, alcohol use, and painkiller use. So painkillers are very frequently even what we call non-steroidal and anti-inflammatories, which are potentially nephrotoxic or bad for the kidneys. They're available over the counter in India, and people can simply go to a chemist shop and buy them and pop them whenever they want to. And so we think that is one of the these are a few potential things that we can fix. So and then we are looking at some other environmental factors also. So for example, quality of water. So we are investigating a whole range of abnormalities in the water, number of heavy metals, silica, nickel, cadmium, etc. We are looking at pesticides. And so we have done all of those analyses. And pesticide, at least in drinking water, there is no pesticide. We found that most of the heavy metals are present in the expected quantities there. So water doesn't seem to be such a major problem. But what we found as a major problem in that area when we actually went and interacted with the community is that perhaps they work in environments which expose them to a lot of heat stress. So these are people who go out and work in the fields. So they go out and work in the fields in hot and humid environment. They don't take any drinking water with them, so they're working all day without access to drinking water. And the second big industry in that area is cashew plantation industry. So cashews, they grow, cashews grow on a tree, and all these workers, they have to go and pluck the cashews when they are ripe. And again, that happens during the summer season, summer and monsoon season. After they have plucked these cashews are roasted. And so they have to go and work at a brick kiln, actually, and roast these cashews. And the temperature there, God knows, goes to what levels. And so we think that there is a lot of heat stress that these individuals are exposed to. And when they sweat a lot, they lose a lot of water, they don't drink water. So the total body water obviously goes down, and when the body water goes down, the circulation to the kidney falls, and this is well known. That when the circulation to the kidney falls, the kidneys are exposed to what is called ischemic stress, and they suffer micro injuries. Or when it happens over a period of days, it adds up and leads to chronic kidney disease. So that's an interest which we now want to explore. And why I put up this paper here is that this is something which has already been explored as a cause in Central America. So in Central America, the population in which kidney disease epidemic has been described is people who work in sugarcane fields. So sugarcane, after the sugarcane has been harvested, stumps are left on the ground, and the way these people get rid of those stumps is just to burn them. And when they burn them again, there is a lot of heat is generated, and people who work in that, they get exposed to that heat. So as a result of that, in Costa Rica and in Nicaragua, the governments have now implemented mandatory water breaks for these people. Is that they have to come back to a shaded area at the end of like every hour, every 2 hours, and water is made available and so on. So we want to investigate whether something similar is happening here as well, and it is quite possible because these are the areas from which kidney disease epidemics have been described in India, and you can see that this map shows the average heat wave days over the last 50 years in different parts of India. That many of these areas actually have had large number of heat wave days. And this is something which Andy and I yesterday, and hopefully there will be ways in which we could investigate this on a scientific basis. So this is interesting. This is a figure which I came across only yesterday, and so this is, I don't know if you have looked at this website, ourworldindata.org. So this figure shows the perception of different health problems around the world. And they looked at it in a number of ways. How do people do Google searches? How do newspapers cover conditions, health conditions, etc.? And so this particular figure shows you the burden of disease, or the burden of death due to different diseases, and the coverage of different conditions in two newspapers, New York Times and The Guardian. And they have created a ratio of the burden of disease and the amount of coverage that the conditions have received. So anything that is on the top, above the line, has received more coverage than is deserved by the number of deaths that are caused by those conditions. And anything that is below the line has received less coverage than the number of deaths that can be attributed to that particular condition. And not a surprise that terrorism has received far more coverage than, if you look at it from the poll numbers perspective. And the condition that has received the least attention is kidney disease. So there is a big advocacy gap there, which is for the nephrology community to fill in. So that was just the last slide, which I thought I'll throw in here. So I'll stop here.